Good afternoon, everyone. Can you hear me? Yes. Okay, we're going to get started with today's presentation. My name is Sarah Jacob. I'm a health educator with Bloomfield Department of Health. I would like to welcome everyone to this lunch hour informational webinar on STDs, sexually transmitted diseases. When you get the chance, you may introduce yourself in the chat so we know who's here in our midst. This session will cover STD trends currently prevalent in New Jersey and some county-specific rates, especially in Essex and Camden counties, reporting requirements that we as public health professionals or healthcare professionals must be aware of, also some CDC recommendations for screening, and finally some guidelines on treatment. This is a collaborative effort brought to you by Bloomfield Department of Health and the New Jersey Department of Health. As a requirement for the strengthening grant, Bloomfield Department of Health conducted the 2022 Rapid Public Health Assessment. And one of the findings noted through this assessment is that Essex County, where Bloomfield is situated, currently has the highest incidence of STDs in New Jersey. Bloomfield alone had 277 cases of STI since 2021. So this presentation is very timely and relevant in terms of communicable disease outreach and education efforts that our audience of public health and healthcare professionals may undertake for New Jersey population. Our speaker today is Amelia Hammerman from New Jersey Department of Health STD program, where she is currently the manager of training and development. Amelia holds 2 master's degrees, one in human sexuality and another in instructional design. She comes here with over 24 years of experience in the field of public health and sexual health education, which includes working with community nonprofits, developing courses and providing education and training to specific populations, from adolescents to professionals to community adults. In addition to these, she has also published articles in national and international journals on the topic of teaching sexuality. So today, our conversation is indeed with a subject matter expert. Some logistics before we get started. Please make sure you're muted so we can minimize all background noise. This presentation will approximately be for 45 minutes, and the last 10 to 15 minutes of the hour will be reserved for Q&A. So you may hold off your questions till then, or you may also type your questions into the chat and we will make sure to address it during the appropriate time. Lastly, you are eligible for continuing education credits through this learning session. So at the end of this presentation, we will share a survey link in the chat. Completing the survey will ensure that you receive CE credits for your attendance today. So without any further ado, I'm turning over this platform to Amelia now.
Good morning, well, almost afternoon, everybody. Thank you so much for coming. And, you know, nothing goes with a nice lunchtime sandwich like some gonorrhea and syphilis. So we'll do that over lunch, because why not? So they asked, I was asked to come and speak to you to give you sort of an overview of what STDs are looking like in New Jersey, and then a couple sort of reminders about testing and treatment. So without further ado, I will get started with some useful stuff to know. Maybe, if I can advance my slide. There we go. All right, so today we're going to talk about some STD trends in New Jersey, specifically chlamydia, gonorrhea, and syphilis. We don't collect data on herpes and HPV because, thank goodness, because then we would just have information about everybody in the state pretty much. So we don't really, we don't collect that data. So chlamydia, gonorrhea, and syphilis, that's really what we look at and do. Some reminders about reporting STDs in New Jersey, and then some quick reminders about screening and treatment. So STDs are certainly going up in the country and in New Jersey. This shows you a little bit about what the rate change has been with the United States compared to New Jersey. So as you can see, we are increasing above and beyond the country when it comes to gonorrhea, and certainly with primary and secondary syphilis. but it's increased all around. Congenital syphilis is a huge concern nationwide and in New Jersey right now. We're seeing a lot of increases in that. So, yeah. Okay. So first off, congenital syphilis, because that's sort of our one of our big rising areas of concern. This map shows you in 2011, the rates of congenital syphilis in each state. The lighter the color, the lower the rates, compared to 2020. So basically in 2011, there were 8 states that had rates of equal to or higher than 14 per 100,000 births. And in 2020, that was up to 36 states with those higher rates. And you can see New Jersey is one of those states with higher rates. So it's definitely an issue, and it's definitely a concern, and it's definitely related to syphilis rates going up overall. This is a simple chart that shows you in New Jersey, we had no cases of congenital syphilis for a number of years. And then that started going up and up and up. In 2021, we had 48 cases, and we are going to be much higher than that in 2022. They just keep going up and up. So that was, this is definitely a concern. We do not like to see babies getting syphilis, especially because it is completely preventable if the pregnant patient is treated at least 30 days before delivery. So we're really trying to crack down on that. We do have a disease investigation team of DIS that are focused on congenital syphilis. So we are really, we have various efforts to really try to get a handle on that. Overall syphilis trends in New Jersey, you can see that it's separated out into primary and secondary, early and non-primary secondary, early syphilis that's not primary or secondary, I should say, meaning early syphilis that's of duration that's been less than a year, but the patient doesn't have any symptoms. So no initial chancre or rash for secondary syphilis. So if it's verified that it's been less than a year, but no symptoms, that's early non-primary, non-secondary, and then late latent. So as you can see, it's pretty much just it's gone up for all of these. We see a little bit of a dip there in early, and then it goes back up. Primary and secondary just kind of seem to be gradually going up and late is a little more hinky with the ups and downs, but overall you can see that we're definitely going up. This is 2020 and 2021 with the counties with the highest rates of syphilis. So unsurprisingly, the highest rates are the counties that have the highest populations and are outside of Philadelphia and New York City. So that's not surprising. But as you can see, we're also seeing increased rates in other counties as well. So it really is becoming more and more prevalent. Moving on to chlamydia. So I just want to point out here that our 2020 data, I don't know that I fully trust it because of the whole COVID thing, and kind of the same for 2021 because STD testing was definitely interrupted by COVID. So folks were not getting screened unless they were symptomatic. So that's going to make us lose a lot of cases. So I don't think that drop between 2019 and 2020 truly reflects what actually happened as far as infection rates. If anything was clear to me during COVID, people were definitely still having sex because we started seeing syphilis, and I'm like, all right, if you're getting close enough to get syphilis, you're getting close enough to pass COVID. So people were not necessarily social distancing as well as they should have. And as you can see, rates are just kind of starting to go back up. So I think we're going to have to wait to see where the data goes to really assess what we're really accurately looking at. Because I think that this is a little falsely decreased. When we break it down into age groups. You can see that 20 to 24-year-olds, that's our highest population with chlamydia, and followed by 25 to 34-year-olds and 15 to 19-year-olds. That's sort of what we're seeing there. Looking at chlamydia by county, again, unsurprisingly, outside of Philadelphia, New York, we're going to see higher rates. But yes, you can see that Essex is in red there. Essex is very high rates of syphilis. I mean, chlamydia, wrong disease. Okay, so gonorrhea. We see things going down a little bit in 2014 and then going right back up. We are seeing some more increases here. Gonorrhea, as you probably know, there's concerns with treatment because we keep finding resistance to gonorrhea. So they are working on trying to find more treatments, and there's been some changes in the treatment guidelines from the last one to reflect what they were finding as far as resistance, but we are seeing gonorrhea rates going up as well. Gonorrhea broken down by age groups. Again, the highest rates are 20 to 24-year-olds, 25 to 34-year-olds. We saw a little bit of a change there, seeing it a little bit more in the older 35 plus populations that sort of took over from the 15 to 19-year-olds. So we're kind of seeing a little bit of a shift there as far as the age groups. Again, by county, it looks a lot like chlamydia. And again, you're going to see it more in the higher population areas, but again, it's everywhere. It really is all over the state. It's all over the country. In Essex County specifically, this is chlamydia and gonorrhea together. So chlamydia is the blue line, gonorrhea is the yellow line. Yes, chlamydia is way more prevalent than gonorrhea. They do often travel together though. So if someone is diagnosed with gonorrhea, they often get treated for chlamydia alongside it just because they travel so much together. And CDC does recommend that patients, if chlamydia cannot be ruled out when they're diagnosed with gonorrhea, that they do get treated for both. So this is what it's looking like in Essex County. It's fairly steady, but it's not going away. It's not going anywhere. And this is number of cases. And syphilis in Essex County, that's just steadily going up. And that's not surprising. And it's something that is a concern. But it is increasing definitely in Essex County, more so than chlamydia and gonorrhea for whatever reason. Okay, so moving along, reporting STDs in New Jersey. What does that look like? Okay, so what happens in New Jersey is a patient goes to their doctor's office or the clinic or wherever, and they get tested for STDs. And the doctor, either, if there's an in-house lab, they send them there, or maybe they'll give them a slip to go to LabCorp or Quest or wherever, and the lab does the test. And then mostly we get those positive tests directly from the lab. LabCorp, Quest, the big ones report directly into CDRSS, which is the Communicable Disease Reporting and Surveillance System. So that's where we get the positive cases. That's how we know there's a positive case. New Jersey is a dual reporting state, so providers are required to report as well. But I'm going to tell you the truth, providers are not very good at reporting. A vast majority of our cases we do get from the lab. So once we get a positive case, it goes through our surveillance, who sort of vets it and gets some preliminary information from the provider, and then it gets assigned to our frontline supervisor, who then assigns it to a disease investigation specialist to investigate. We have those at the health department, and we have those. I'm sorry, my phone is going off. I'm going to shut it up. So we have DIS at the state level and we have DIS at the local health departments that might follow. We really only follow syphilis at this point. We just don't really have the bandwidth to do partner services for the other STDs. So it's really syphilis. So then after we investigate it and we have all of our data and information, and that all gets put into CDRSS, and then our data folks generate a report with de-identified data that gets sent to CDC so that we can have lots of nice, good national data. This is a little, that link there, will tell you what diseases. It's a handy dandy little magnet that was done, but you can print it out and that tells you what diseases need to be reported where and in what timeline. And Chapter 57 of New Jersey Code says that healthcare providers and administrators have to report within 24 hours the information that's below there. So STDs and HIV and all of that. And most diseases get reported directly to the local health department. However, sexually transmitted diseases, hepatitis C and tuberculosis get reported directly to the state health department. So that's a little different with other communicable diseases. So a lot of communicable diseases get reported to the local health department. STDs, hepatitis, tuberculosis, they get reported directly to the state. But what about HIPAA? How can we report and give all that private information about patients? Some providers or folks that work in their office have these questions, but public health reporting is mandated by law. By law, it has to be reported. It's not really affected by HIPAA. And HIPAA specifically says that public health reporting without a patient's authorization or consent is allowable. And for public health purposes, it is okay for us to get that information about patients because we are the Department of Health and we're doing this for public health purposes. So we are HIPAA exempt. There is an STD report form that is online. We are currently working to sort of break this up into syphilis and gonorrhea and chlamydia separately, so it's not all on the same sheet. But providers by law are required to report all the reportable STDs to us within 24 hours. And once we get that report, then we go through the process of assigning it to a DIS to investigate the case and provide partner services. Any information requested by DIS helps the investigation. So we really try to communicate that to providers when we do reach out to them initially, that if they hear from a DIS, please cooperate because they're following the case and it's just only going to help them, whatever information they ask for. So in this form, this disease report form can be found on our website and it can be filled out and faxed in. So that is how diseases are reported.
Hey, Andrea, sorry to interrupt. This is Samantha. We have a question in the chat, 2 questions. Is the 2013 the most recent magnet for the reportable diseases?
Yeah, the one that links to, yeah, that is. They haven't really done it in a long time. But okay. It's still, as far as when and where, it's relevant.
Okay, and then will we be sharing this PowerPoint after the program? Okay,
sure, that's fine. Yeah, it can be sent out to everyone. It's not a problem.
Okay.
Yeah, I will provide it and it can be shared. Well, you already have it, so you can share it. That's fine. Yeah. Okay. So I just want to go over screening a little bit. In New Jersey, it is required by law to test a patient for syphilis who's pregnant. And that testing needs to happen at the first prenatal visit. And it also has to happen at the time of delivery. We also are recommending, given our increased rates of syphilis, we also, even though it's not the law, we do very much recommend and very much hope that physicians who are seeing patients for pregnancy also retest it early in the 3rd trimester. Because what has happened is we have seen a number of cases in which a patient is negative at their first prenatal visit. They get the syphilis test, it's not reactive, nothing gets done, and then they don't get tested again till delivery, and at that time, they now have become positive. So we did not have any opportunity to prevent syphilis from getting to baby. So we really do encourage providers to also test early in the 3rd trimester, because we have seen that happen, and we want to make sure that there is time to get them treated at least 30 days before delivery, because that is very likely to prevent congenital syphilis. HIV is also, physicians must recommend and provide, that's the language of the law, HIV testing as early as possible and in the 3rd trimester. And the mother's HIV status should be documented at work. Excuse me. And any additional STDs, they're not noted in the law, but certainly a pregnant patient should be tested for them, because that can certainly affect the baby as well as the patient. So a brief summary, and this is by no means comprehensive, so I really recommend that you go and look at the more comprehensive screening guidelines. That the link is there at the bottom. But CDC recommends that all adults and adolescents 13 to 64 get at least one HIV test. Sexually active women who are under 25 or older women with a risk factor should get an annual chlamydia and gonorrhea screening. Pregnant patients, as we discussed, they need to get syphilis, HIV. They should get hepatitis B screening, and any additional STD screening if the patient is at risk for STDs. Sexually active gay, bisexual, and other men who have sex with men, it's recommended that they get annual syphilis, gonorrhea, and chlamydia testing, and probably HIV testing every 3 to 6 months. If a patient is having unsafe sex, if they're sharing drug injection equipment, and that's not just the needle, that's all the equipment, they should get tested for HIV at least once a year. But that's just sort of a nutshell. I definitely recommend going to that link at the bottom of the page to see the comprehensive recommendations. There's some additional recommendations for pregnant patients, and that is that patients who are at an increased risk, again, get tested early in the 3rd trimester. And as I mentioned before, we are recommending that statewide, because one of the increased risks is living in a community with an increased rates of syphilis. And since we're seeing that increase all over New Jersey, we are definitely recommending that. And that recommendation for, again, in the early 3rd trimester is supported by CDC. It's supported by the American College of Obstetricians and Gynecologists. It's supported by the American Pediatric Association. I don't know if I said that right, but you know what I mean. So it's very supported by all the professional medical organizations, all the relevant ones. All sexual partners of patients diagnosed with syphilis should absolutely be tested and treated, because we don't want that pregnant patient to then get reinfected right after we treat them. So that is really important. So before newborns are discharged from the hospital, the serological status needs to be confirmed. A patient or a baby should not be discharged from the hospital before we know mom's syphilis status. And if mom has syphilis, the workup on the baby. Any patient who delivers a stillborn, which is defined as fetal demise after 20 weeks, should also be evaluated for syphilis to see if that was a factor in the pregnancy loss, in the baby's death. Excuse me. Oh, I did not update that bottom there. See 2015 STD treatments. I did not update that link. But if you Google STD treatment guidelines, you will get the most recent ones. So the 2015 ones you won't even find on there anymore. I apologize for not updating that bullet on the slide. So treatment. I'm not going to go down all of the treatment recommendations, but there CDC has pocket guides that you can order some of. There's a printable version of the screening guidelines. There's an app that you can download for your phone, which is really helpful, but that has all of the guidelines for treatment, and there have been some changes with gonorrhea treatment and syphilis. The recommended treatment, of course, is penicillin, and doxycycline is the alternative if there's an issue with penicillin. Well, that went by a lot faster than I intended. So what questions does everybody have?
Yes, so this is the time. If anyone has questions, they can unmute and ask or put it into the chat. But we have two questions here. What does the antibiotic resistance look like currently when it comes to treatment?
Okay, so the current recommendation addresses that. Of course, I don't have my guidelines right next to me, but basically, they changed it to medication that is more effective. And another thing that's important with gonorrhea and chlamydia screening is the site-specific testing. So if a patient only had oral sex, you're not going to find gonorrhea or chlamydia if they pee in a cup. They need to have a swab of the site at the site of infection. So we do recommend swabs for the throat, anal swabs, urethral swabs to get that information at the site of infection. And if chlamydia cannot be ruled out, then the patient should also be treated for chlamydia. So basically, do I have it written down somewhere? We are working on kind of our last hope with gonorrhea. We are not seeing in New Jersey. We are currently, now that we have more staff, we're doing more work on gonorrhea and more work on following up with some of those cases to try to determine whether or not we're seeing more resistant gonorrhea in New Jersey. But as far as we know, the recommendations are effective treatment for gonorrhea, but they really do need to be followed. I hope that answers the question.
Okay, thank you for that answer. Second question, how are providers made aware of the testing and reporting requirements, and how can local health departments improve our communications?
That is such a good question. We do typically providers that are more specific to STD, right? So like HIV providers at STD clinics, those kinds of things. Those providers are usually more up on the guidelines than your general practitioners, the general providers. Sometimes they kind of, they're not as up on it. But when we do a number of things to try to educate providers, we do provide resources. We do an STD clinical update every year, which is mostly for the clinic providers, the STD clinic providers. We have been reaching out to delivery hospitals with where there have been congenital syphilis cases, and we've been doing education for those providers to remind them about the guidelines and make recommendations, so that we do that. So we do a lot of provider education as it's requested. And I've got, a few already coming up that we're going to do. Local folks, local public health folks, you might have a better relationship with the providers in your area because you are in that community. So anything, to do to sort of, drop off, a handbook of treatment guidelines, or if you're seeing a provider that's not doing the appropriate treatment, if you know that's an ongoing problem, you can certainly reach out to us and we can help with that. But as far as getting that information to the provider, it's really their responsibility to know, but it is really helpful for local health to develop those relationships with their providers so that they can be a resource if the providers have questions.
Okay. You mentioned that there's going to be STD clinic update. Do you have an idea when this year that would be?
Yeah, it will be in the fall. We don't have a date scheduled yet,
Okay.
but we are looking to the fall to do an STD clinical update.
Okay. I have a question from Lori. Lori, do you want to clarify your question? I'm not fully understanding.
Hi. I thought you can screen for chlamydia with a urine sample.
Yes, you can. However, if the chlamydia is in the throat or the anus, that urine sample isn't going to
Oh, that'll show negative.
Right. So
Okay.
the urine sample only works if that's where the chlamydia is.
So if you were to do maybe testing on adolescents, obviously you're not going to swab the throat, or if you were just to do regular screening, could you use the urine?
Yeah. And I know in Philadelphia, a number of other places, they've done sort of general chlamydia and gonorrhea, chlamydia screening in schools or whatever. And they, have the students line up and go in the bathroom and pee in a cup and hand the cup in and all of that. So for sort of general screening purposes like that, sure, yes. But if a patient comes in to ask for STD screening and says that then it's good to try to find out what sort of sex that they've had so that you can do site-specific swabs. But for just sort of general screening, yeah, urine test is still widely used.
Okay, thank you.
Question from Jennifer. Why do you think the younger demographic is not practicing safe sex? Do you think it is attributed to advancements in HIV or AIDS treatment?
So we get asked a lot, why are STD rates going up? Why are they so prevalent in younger populations? All of that stuff. And the answer is it's like all of the above. There's not one single reason. Yeah, some folks say, oh, it's because of PrEP, because, people go on PrEP and then they think that they're okay because, they're at such low risk for HIV that they don't have to worry about other STDs. That's why it's real important when a patient goes on PrEP that provider do some education with the patient to make them understand that it's only HIV. That's not going to protect them against syphilis or chlamydia or anything else. It's also why when a patient is on PrEP, they get regular STD screens. But it's not all because of PrEP. We have our apps. People are like, oh, it's because of all the apps. Sure, that's certainly a factor. Social media, all of those things. So there's just a number of, and then, prior to COVID, our funding, as you probably all are very aware, our funding for STDs just kept going down and down and down. So clinic hours were reducing, clinics were closing. We just did not have the resources. So it's sort of just sort of a perfect storm of all kinds of different things that I think have added to the increasing rates of STDs. And I don't think it's necessarily because young people just don't use condoms. A lot of people just don't use condoms. It's just true. And certainly sex education in our country has left a lot to be desired. In New Jersey, it is mandated that students get sex education, that they learn about STDs, that they learn about HIV, that they learn about all of that. But exactly how and what is said is kind of up to the individual school district, school teacher. So it's a little inconsistent about what information young folks are getting. So it's just, there's all kinds of reasons why STDs are increasing and why folks may not be using a condom. And keep in mind that a condom is only going to protect A condom is really most useful for chlamydia and gonorrhea, and syphilis if that chancre is under the condom. For ones that are skin to skin transmission, like syphilis and HPV and herpes, a condom is less effective. It certainly helps, but it's less effective than for the ones that are transmitted through fluid.
Okay. You've probably touched on this, but the question is, can you speak a bit more about the rise in congenital infections and what education resources are available for increasing maternal child health outreach?
So, fortunately, our First Lady has sort of made it her mission as the First Lady of New Jersey to address some of the maternal health disparities in New Jersey, because we see a lot of more negative maternal outcomes with non-white patients. So she has sort of made that her priority to address that. So we are seeing a little more resources and a little more attention to that, which is really good and helpful. And I'm very glad for that. Congenital syphilis, pretty much when you see rates in female patients of childbearing years go up, then you're going to see congenital cases go up, because once it starts to get, we still have the majority of syphilis cases in men and men who have sex with men, but we're seeing it more in females. And when you see it more in females of reproductive years, it's going to get to the babies. So there was a public health campaign that was done a number of years ago. You can still go on our website and get those posters that are in many different languages that provide some education about the importance of getting screened for syphilis during pregnancy. We do reach out to providers. As I said, we have a much bigger DIS team, and we are, have some different protocols in place for prioritizing pregnant patients that come in with a positive syphilis test, to try to make sure that they are getting treated right away. So we have all of those initiatives, but really, when you see syphilis rates go up overall, you're going to then see them start to get to females, and then you're going to see that start to get to babies. That's just kind of how it works. So honestly, it's like, and to just try to find, because, we have over 100,000, I don't even know how many live births we have in New Jersey, well over 100,000 a year. And there were 48 cases of congenital syphilis last year. So that's a really small percentage. So it is a little like finding a needle in a haystack. So if that's the case, then rooting through that haystack to find the needle is probably a lot less productive than trying to just shovel away that whole haystack. Eventually you're going to get those needles. So we're really trying to focus on syphilis overall at the same time that we are kind of trying to pick through and find those needles in that haystack, if that makes any sense.
Okay, thank you. You mentioned that we could get posters in other languages through the website, but the question from the audience, do you have information in different languages that we can share in diverse communities with language barriers?
So mostly, so the STD brochures, the general STD brochures, we count on CDC, because there's no need to reinvent the wheel specifically for New Jersey. They have all the information that needs to be there, and I think mostly are in English and Spanish. The congenital syphilis posters are in 6 languages on the web: English, Spanish, Arabic, Creole, I forget what else, but there's a number of languages on there that they are. So that's at least that resource.
I shared in the chat the links for the posters, and it says that congenital syphilis posters are in multiple languages, not just English, Spanish.
Yeah, I think there's 6 languages total that they have there.
Okay, and we have one more question from Samantha. What survey data is used to understand sexual behaviors in New Jersey other than the New Jersey BRIFIS?
So the youth risk behavior survey is done in high schools. There was a little bit of a pause in New Jersey participating in that for a while, but I believe that we are doing it again in schools, and that gives us sort of an idea of what adolescents are, what they're doing, and that gives us an idea of that. And that's probably the biggest like overall source besides that. And otherwise, there's no like big survey or you know, things like that. That's the YRBS and the one you mentioned, that's probably our best tools for sort of wide information about that. Otherwise, it's just sort of anecdotal that we get from DIS through their interviews.
Thank you. That completes all the questions that I have. If there's any other questions among the audience, you may unmute and ask right now.
Amelia, this is Samantha again. I guess just following up on that last question that I have, my thought was we have this rise in cases clearly with your first couple slides, and the data is suggesting that it's definitely an issue. And, you know, behavior is definitely a piece of the prevention here, understanding what's going on. So, you know, local health and clinicians and providers can, you know, intervene. How are we going to tackle this issue if, you know, sexual questions, sex ed questions about sexuality is still kind of one of those subjects that people can opt out of answering the questions, or certain school systems, even the public school systems, are uncomfortable asking those questions? Is there anything that the Department of Health has been talking about, or some solutions that potentially could give us a better idea of behaviors in the future?
Okay, so I sort of feel like there's a couple different questions there. One is, what are we doing to talk about sex? Because yeah, sex is taboo still in this country. Sex is something you do. It's not necessarily something you talk about. There is a great, in my presentation that I've been doing for prenatal providers, I do spend some time talking to patients. And there's a good quote that I use that says that talking about sex requires more intimacy than actually having sex. And it's uncomfortable. It is uncomfortable in our country. It is uncomfortable. And so what I really try to impart on providers is, you got to bite the bullet and do it. Go to CDC. I give them some resources. There is a provider guide for collecting a sexual history. And they talk about, you know, the information that you should get, like partners, practices, any past history of STDs, what the plans are for having babies, or, you know, with themselves or their partners having a baby. Because this is stuff that needs to be talked about, not just with the people that can get pregnant, but their partners too. And it's really important. And I really try to emphasize that the more you do it, the more comfortable it's going to be. And it's going to be awkward at first. And it's fine. And it's important to tell the patients that this is just a part of their overall health. You're not trying to be nosy. You're not judging. You're just trying to get information so that you can do, you know, get the appropriate screenings and tests, and, you know, help them get information that's going to protect their health. And it's hard to do. And on top of that, there's assumptions that get made all the time. I use myself as an example. You know, often with providers, I'm like, if I walk into your office, what assumptions are you going to make? We're human beings. We make assumptions. I'm not going to tell people don't make assumptions. I'm going to say, don't let that assumption be your final word. You need to follow that up. Recognize that you're making an assumption, which may or may not be right, and follow it up. So if I walk into a provider's office, you might make some assumptions. You see, you know, middle-aged white woman. Oh, you know, yeah, she's low risk. You know, she falls into a demographic, and, you know, with a ring on my left finger, she falls into a low risk demographic. Don't really have to worry about her. Don't really need to talk to her about sex or STDs because, you know, she's low risk. Well, Statistically, yeah, I may be in a lower demographic, but that does not have anything to do with my actual risk, because it's about what you're doing. Until you have a conversation with me and know what I'm doing on a Tuesday night or Saturday night, then you don't really know what my risk factors are. You need to have those conversations. And the more you have those conversations, the more comfortable they'll be, and the more accepted they'll be, the less taboo they'll be. As far as sex education in schools, yeah, that's an ongoing problem. We do work with, there is, in the Department of Health, there is, the adolescent health program, and we do work with them to try to give input into the state education guidelines about what should be included and not. So we do work with that, and we have worked with them to try to get that youth risk behavioral survey more implemented again, so that we do have a better idea of what folks are doing as far as their behaviors that might put them at more risk or less risk. But yeah, it's absolutely a challenge. It's absolutely a challenge to talk about it. It's absolutely a challenge to get all that information, because people don't want to talk about it. They don't like talking about it. It's taboo. It's something you do. It's not something you talk about. Does that answer your question?
Yeah, I think it gives an
Okay.
idea of what's going on. It's, I think if we can stress that, sexual behavior has repercussions in terms of health, that would be helpful for at least the local health departments to try to increase that outreach.
Yeah. And another thing that I like to emphasize is, we don't want to like be sex negative. People have sex because they like it, because it feels good, because, and that's fine. Having sex is a perfectly healthy part of being an adult. If, of course, there are some people that choose not to have sex or don't want to have sex, and that's fine too. But sexuality is just, it's a normal part of life. It's a healthy part of life. It's just a matter of, if you're doing it and you're getting these infections, what can we help you change a little bit to make it less likely that this will happen again? Or, that kind of a thing. We don't want to shame people. We don't want to tell people just not to have sex. Like that's, it's ridiculous. And especially when you look at, HPV and herpes and all of, the ones that we don't collect data on as well, that nationally, and they estimate that at least 70% of sexually active people will have HPV at some point in their life. STDs are normal. It's less normal that no one will ever have an STD. So it's normal that someone will have an STD at some point in their life. So it's really, how are you going to deal with the presence of STDs? Because they're not going away. And if it's not you, it's going to be a partner, it's going to be a friend, a family member. So just, how are we going to deal with STDs as part of life, rather than seeing it as a don't, never get it, because that's just not realistic.
Awesome. Thank you.
Thank you, Amelia. At this moment, I am sharing in the chat the survey link that you can complete to receive your continuing education credits. If you have any questions, please unmute and ask at this time also. And I want to thank Amelia for joining us today, bringing us this very vital information that we can use in our in the work that we do in New Jersey. Samantha, anything else?
Nope, just Amelia, if you could just keep me updated and on any other resources that you find or think would be useful within the next week or so, I can send that and share that with the group here.
Sure.
But that's all. So thanks everybody for joining us today, and I will send you the survey link shortly after the program concludes, so that we can ensure that you get your credits. So thank you.
Thank you.
Thanks so much, everyone.